I would like to thank you very much for the invitation, Carlos, and you, Matt, for the kind introduction. And I would like to talk to you about the extensor apparatus of the fingers. To understand the biomechanics, oops, I would like to get rid of this in the top. Anterior. Well, to understand the biomechanics of finger deformities, we need a good knowledge of the anatomy, in particular the extensor apparatus. The extensor tendons only exist at the distal forearm and the dorsum of the hand. These are the extensor tendons from the muscle unit in the forearm to the base of the fingers. And on the fingers itself, they're not really tendons. It's called the extensor apparatus. So tendons are only in this area right here. Extensor tendons only extend the MP joints. As we can see when we have a claw deformity of the hands with a palsy from the ulnar nerve lesion or median and ulnar nerve lesion. And here we can see the action of the extensor tendons, extension of only the MP joints, because they don't have intrinsic muscles because of the nerve lesion. The extensor tendons are held at the dorsum of the MP joint by the sagittal bands, but they do not insert into the proximal phalanx. This is the metacarpal-proximal phalanx, extensor tendon right here next to the bone. Here's the PAP joint, and here the flexor tendons, the profundus and the sublimis. Here's the volar plate of the MP joint. So as you can see here did a longitudinal incision on the hood, extensor tendon hood, and we can see this collagen tissue, connective tissue, but this is not a real tendon insertion. This is just for stability or probably more for vascularity of the tendon. Is like a vincule, but it's not a real insertion of the tendon into the proximal phalanx, which is right here. When we do a release of an MP joint extension contracture, like here, in one finger or several fingers, we divide longitudinally the extensor tendons. And after the extensor tendon is divided and retracted both sides, then we can remove the dorsal capsule, and we can see that the extensor tendon does not insert into the proximal phalanx. Then, if needed, which is in most of the cases done, then we cut the insertion, well, the origin, I should say, of the collateral ligament. So we put the blade at the axilla between the collateral ligament and the metacarpal head, and we turn the blade around 90 degrees, and then we cut the extensor tendon until we are able to flex the MP joint. And we can do a tenolysis, just putting some scissors under the extensor tendon between the extensor tendon, well, the apparatus, extensor hood, and the proximal phalanx. But we will see that there is no insertion into the proximal phalanx. Then, how do they extend the proximal phalanx, the extensor tendons? Same as with horses, with reins. We don't need to have a direct insertion of a tendon right here to the neck. We can put a rein here in the mouth of the horse, and then we can get the extension of the joint. And by pulling the extensor hood and the sagittal bands, the extensor tendons will extend the MP joint. And in order for the extensor tendon to extend the IP joints, proximal and distal interphalangeal joints, we need to flex the MP joint, because otherwise there is not enough exertion of the extensor tendon to extend the MP joint, the PAP joint, and the DAP joint. But even with patients with a claw deformity, that they don't have intrinsic muscles, we can, the extensor tendons can extend the interphalangeal joints if we hold the MP joint in flexion. And this is the role of the intrinsic muscles. They pass polar to the axis of rotation of the MP joint and dorsal to the axis of rotation of the PAP joint. So the intrinsic muscles, what they do is flex the MP joint and extend the interphalangeal joint. This is a clinical case of intrinsic muscle fibrosis. This is described by Finocchieto, in which we can see that the muscle has been fibrosed and it's contracted, it's retracted. There are no creases here, and the MP joints are flexed and the interphalangeal joints are extended. So, as we said before, the extensor tendons are only here, from here to here. And then at the back of the finger and the side of the finger, we have the extensor apparatus, which is what we will try to look in more detail from now on. Here in this drawing that I made, I showed the MP joint, but really this, to be more accurate, this should be right here, because the sagittal band goes from here to here, from the extensor tendon to the volar plate of the MP joint. This is the intrinsic muscle, well, the interossei, because there's another intrinsic on the radial side, which is the lumbrical. The lumbrical is more anterior because it originates in the flexor tendon, and it passes volar to the intervolar plate ligament that we will see in a moment. It seems complicated, but to make it easier to understand, we should think that the extensor apparatus is triangularly shaped, with the base proximally and the apex distally at the distal phalanx. And the base is at the level of the MP joint. And this is the base. And this is the extensor apparatus. Here we have the extensor tendon dividing into two slips, two lateral bands, and one central slip. There's a patient that was beginning to have a boutonniere deformity. This is the transverse retinacular ligament, and these are the interossei muscles. This is the index finger with the first dorsal interossei, which is the strongest muscle in the body in relation to the width and the length, and the lumbrical, which is only present on the radial side of the finger, because it comes only from one tendon, the flexor tendon. So what are the parts of the extensor apparatus? One is the extensor hood in yellow, all this part right here that goes around the proximal phalanx. This is the hood of the extensor apparatus. Then we have the central slip, which is the direct continuation of the extensor tendon that inserts at the dorsum of the base of the middle phalanx. And then we have the lateral bands, which is, they come one on each side. Here's the central slip, this one lateral band, and here's the other lateral band. In both the lateral bands, they join together to insert distally at the level of the dorsum of the distal phalanx. But this is not like a cord or a rope, like a flexor tendon or any other round tendon. This is an apparatus, and it's bidimensional, it's flat shape. So we need some structures to stabilize it. We don't have pulleys here. We don't need pulleys, but we need stabilizing structures. Which are these stabilizing structures? They are painted here in green. We have the sagittal bands that stabilize the extensor tendon on top of the head of the metacarpal. Then we have the transverse retinacular ligament here and here, here, which prevent the lateral bands to displace dorsally, like when a person does a hyperextension of the PAP joint or a SWAN neck deformity. And finally, we have the triangular ligament. Triangular ligament unites and holds together both the lateral bands to prevent them to displace excessively anteriorly. So sagittal bands stabilize the extensor tendon, and then transverse retinacular ligament that prevents the lateral band to go excessively dorsal, and triangular ligament that prevents the lateral bands to go excessively volar. And this is the oblique retinacular ligament that we will discuss later on. First, we'll look at the traumatic lesions. Traumatic lesions are quite simple to diagnose and to treat, really, unless they are chronic lesions. And they are classified by zones. There are 8 zones, 1, 3, 5, and 7. Odd numbers are on the top of the joints. So number 1 is the DAP joint, number 3, PAP joint, number 5, or zone 5, MP joint, and 7, the extensor retinaculum and back of the wrist. And the even numbers are the sections of the tendons in between. Here's the flexion tendon with the flexor retinaculum, and this is the flexor tendon sheath. And this is a good classification and quite easy to remember. The only thing I don't like it is that it's numbered opposite. It's usually done in anatomy. In anatomy, usually number 1 is the most proximal part, like C1, vertebra, or root, etc. And here it's the reverse. And probably the explanation is because Claude Verdun and Jacques Michon in 1961, they decided to do it this way. I don't know. The French always are a little special, but no, I don't want to offend them. And that's why the reason that first they did it with flexor tendons and then they continued with extensor tendons. What is more difficult to understand are the alterations of the extensor apparatus that happens in rheumatoid arthritis. In rheumatoid arthritis, we can see an ulnar drift of the fingers, loss of extension of the fingers. We can see this is the same patient, the left hand with a gamekeeper's thumb, the opposite hand with a reverse gamekeeper's thumb. In the same hand, a SWAN neck deformity, and in the same hand, boutonniere deformity. And here, SWAN neck deformity was synovitis of the flexor tendon. And this is a little bit more difficult to understand because all the deformities occur not suddenly, like in an accident, but they appear very slowly, and they're imperceptible to the patient or even to the doctor. We'll start at the metacarpophalangeal joint. Metacarpophalangeal joint, here I remove the metacarpal, and here we're left with the proximal phalanx in green, the extensor tendon held in the dorsum of the head of the metacarpal, which is here, by the sagittal bands. The sagittal bands, they hold the extensor tendon. They divide in 2 little bands. The thinner one is more superficial, and the thicker one it's deeper located. In the sagittal bands, they try to keep the extensor tendon on top of the metacarpal head. In the sagittal band, they insert both sides of the volar plate. The volar plate is attached to the proximal phalanx. And this is the intervolar plate ligament that we will talk about later on. This is the intrinsic interossei muscle, comes from the metacarpal, originates in the metacarpal, and this is the lumbrical muscle that passes below the intervolar plate ligament because it originates at the flexor digitorum profundus. Now, in a cross-section, we'll see metacarpal head in yellow, extensor tendon on top of the metacarpal head, sagittal bands holding the metacarpal head, the extensor tendon on top of the metacarpal head, and then here we have the lumbrical underneath below the intervolar plate or the transverse metacarpal ligament, and here the interosseous ligament, the interosseous muscle with an insertion into the extensor apparatus and another one into the bone. Now here we have the extensor hood and the sagittal bands. They are when one looks at the anatomy or the surgery, they are very close one to the other, and it's very difficult to define exactly where is each one. Usually, the sagittal band, which I painted here in blue, it's a little bit deeper, and the extensor hood goes a little bit over, but they interconnect together. He put a probe in the extensor hood. This is distal, and this is proximal, and this is the sagittal band holding the extensor tendon on top of the metacarpal head, and this is the extensor hood. The sagittal bands, they hold. The function of the sagittal band is to hold the extensor tendon on top of the metacarpal head, because there is no real insertion, as we said before, of the tendon into the base of the proximal phalanx. So something has to hold it in place. During flexion of the joint, radial inclination or ulnar inclination, which usually is larger in the fingers. There is more ulnar inclination than radial inclination, but the extensor tendon always has to be on top of the metacarpal head. Otherwise, it would be ineffective for joint extension. Rupture of the radial sagittal band causes an ulnar dislocation of the extensor tendon. And as a consequence, we will have a loss of extension. Here, the patient here on the left is closing the fingers, making a fist, and he is trying to extend the fingers. And since the extensor tendon in these fingers is not on top of the metacarpal head, cannot extend these fingers. And even they will have a tendency to go on the radial side and even cause flexion of the joint. This is an MP joint schematically. Extensor tendon, proximal phalanx, metacarpal, interosseae, intrinsic muscles, and extrinsic flexors, intrinsic flexors and extrinsic flexors. What are the structures? The most powerful structures, the flexors. We have the intrinsics and the extrinsics, sublimis and profundus. Profundus this one, sublimis here is dividing in two, and then will become his anterior, and then will become dorsal posterior. But what is holding the proximal phalanx in place? Because most of the forces tend to flex, displace the proximal phalanx anteriorly. These are the collateral ligaments. Collateral ligaments, they originate at the dorsum of the head of the metacarpal, and they insert at the base of the proximal phalanx. Not just at the base, but really anteriorly. As you can see here, this is a metacarpal head, and here is the proximal phalanx in 90 degrees of extension or hyperextension. And you can see that the collateral ligaments, they insert at the bottom, at the most anterior part of the proximal phalanx. So these are the only two structures, sagittal bands and collateral ligaments, that hold the proximal phalanx. They prevent the proximal phalanx to dislocate anteriorly. If we have a synovitis from a rheumatoid arthritis, synovitis is like a tumor. It destroys rheumatoid synovitis, not like other synovitis. All of them destroy a little bit, but this is highly destructive. It's like a tumor. They will elongate and destroy the sagittal bands, and you will see it here. They will elongate the collateral ligaments, and some stability it's prevented also by bone morphology, because it's a concavity and a convexity. But as you can see, the collateral ligament inserts in the most anterior part of the proximal phalanx, precisely to prevent anterior dislocation, subluxation from the pull of the flexor tendons. And this is what happens in the rheumatoid arthritis. This is the drawing that we have seen before, normal anatomy. And this is what happened. We have a synovitis of the MP joint, metacarpal head in yellow, base of the proximal phalanx in orange. And we can see that the synovitis has distended, elongated the sagittal bands by the same radial because the lumbrical is here, and ulnar because it's the opposite intrinsic, and here the collateral ligaments. And this subluxation, sometimes it's quite visible on the X-rays, but many times it's not visible. But you can explore them, and you can tell if a patient has had a synovitis of the MP joints in the past. You can tell by doing drawer signs in the knee. You can see the stability. You can tell if the collateral ligaments, they have been elongated. And the patient will be surprised that you can push the proximal phalanx underneath the head of the metacarpals, or even do an anterior-posterior displacement, which is possible in normal fingers, dorsally, but not anterior. Anteriorly, it's impossible, always dorsally. Here we can see the anterior dislocation quite clearly. What happens, this is normal, this at the early stages of the synovitis, both sagittal bands and collateral ligaments elongate, and the patient has an instability of the MP joints. And then as with the passing of time, since the forces are greater pulling the tendons towards the ulnar side, this is the radial, this is the lumbrical, the extensor tendon dislocates towards the radial side of the metacarpal head. At first, the ulnar sagittal band, it's lax, like here. It's redundant. But with the passing of time, the sagittal band will remodel in a shorter position. So this is a late stage of deformity of the MP joint deformity, loss of extension because the extensor tendon is not able to extend the MP joint, ulnar inclination of the finger, and then remodeling of the ulnar sagittal band. And this is quite important to realize or to make a diagnosis because here, I will go back for 1 second to the onset of the deformities. The onset of the deformities usually is in the small finger. First the small finger, ring finger, middle finger, and radial finger. Although most of the times in most rheumatoid patients, the main synovitis is in the index and middle fingers. But since the forces are greater towards the ulnar side on the middle finger because of the intrinsic muscles, hypothenar muscles, and the shape of the metacarpals and some other things that I don't have time to explain now, the finger, the extensor tendon dislocates towards the ulnar side. But in the early stages, like in this case here, the patient himself will notice that putting the fingers in extension, holding the fingers on top of a table, or the surgeon putting the fingers in extension, and we ask the patient to hold them in extension, he will be able to maintain them in extension by contraction of the extensor tendons, because the ulnar sagittal band, which is elongated, will allow for the extensor tendon to be placed on top. And the patient can maintain the fingers in extension as long as he pulls the muscles as the muscle contracts proximally. As soon as he doesn't contract the extensor tendon, the fingers will drop again, and he will have a loss of extension. Ulnar directed forces are always greater, and that's why there is always ulnar subluxation of the extensor tendon. Even in traumatic cases, you always will see very rarely, it will be on the radial side. It's almost always on the ulnar side. Here's a drawing that shows the base of the proximal phalanx in yellow. This is the head of the metacarpal. In red, this is a normal. And this is the intervolar plate ligament that goes from one volar plate to the other one volar plate. This is the flexor tendon sheath, in this case, the A1 pulley, the beginning of the flexor tendon sheath, and here the extensor tendons. Since the forces are greater towards the ulnar side, first dislocates the extensor tendon from the head of the metacarpal of the small finger, and then the ring finger, and eventually the middle finger, and more rarely the index finger. The fingers are united by the interpolar plate ligament. What the anatomists they call deep transverse metacarpal ligament, but they think it's a misnomer. This is not right, because this ligament does not insert into the metacarpals. It goes from one volar plate to the other volar plate, from one volar plate to the other volar plate, as we can see here. So this is the insertion of the sagittal bands in blue. So the fingers are united volarly by the intervolar plate ligament, and once we start having a dislocation of extensor tendon of one finger, the other ones will follow, because the fingers are held together anteriorly by the intervolar plate ligament and dorsally by the junctura tendinea, which are usually quite distal. They usually are up the level of the web space, almost at the head of the metacarpal. Well, this is, I'm sorry, I mentioned this before, that after the ulnar sagittal band has remodeled in the shortened position, like in this case here, this is the head of the metacarpal of the small finger. Here's the extensor tendon, the communis and the proprius of the middle of the little finger. Then if this has been shortened, then in order to replace it surgically at the dorsum, we have to divide the ulnar sagittal band. There is no way, it cannot be done any other way. So you cannot approach the MP joint by doing this and doing application. You have to cut the ulnar sagittal band, and sometimes the deformity is very important, a little bit of the extensor hood, not much, not to destabilize the finger, the stability and the extension, but mainly for the correction of the deformity. When the extensor tendon falls below the axis of rotation, it should be here on top of the metacarpal, the head of the metacarpal, and it falls below. Here the patient has been asked to close the fingers, and she can close them quite well because the PAP joints are relatively well preserved, and the MP joints also. But if you ask them to extend the fingers, he even flexes more the MP joint, because the extensor tendon has fallen below the axis of rotation. So if you put the examining doctor puts a finger here, and you ask the patient to extend the finger, you will feel that instead of extending the finger, the patient flexes even more the finger, and even rotates the finger into supination. So with one finger, you can correct the position of the finger, correct the supination, and correct the flexion deformity, and ask the patient to extend it, and you will see that the finger supinates and flexes, because of the extensor tendon is not placed where it should be. So the effect into the MP joint is ulnar inclination, flexion, and supination of the finger. This much has been said about the cause of the ulnar drift of the fingers. In the ulnar drift of the fingers, from my experience, in what I understand, it's only due to dislocation of the extensor tendon. You'll never see an ulnar drift of the fingers with the extensor tendon placed on top of the metacarpal head. And what we see many times, which we see sometimes shortening of the ulnar intrinsic muscles. This is a secondary deformity, because the origin and insertion of the muscle is closer together, and obviously it will remodel in a shortened position. In the radial inclination of the metacarpals, frequently seen when there is a normal drift of the finger, of the fingers is not the cause of the ulnar drift of the fingers. As Jules Shapiro said, and it has been repeated in all the texts over and over, the radial inclination of the metacarpals, it's a volitional deformity of the patient in order to align the fingers along the long axis of the forearm. But once the ulnar drift of the fingers is corrected, the radial inclination of the metacarpals will spontaneously correct. It's the same as when you see a fracture of the distal end of the radius, what is known as a Colles fracture. The patient doesn't come to you with the wrist radially inclined or dorsally in extension. The patient always has the wrist straight, regardless of the deformity of the radius, because the patient always wants to have the fingers aligned with the long axis of the forearm. So in ulnar intrinsic contracture can be both intrinsics or usually most on the ulnar side. And how can we tell? Because do we have to release the radial intrinsic? No. In most cases, it's not necessary because you don't want to lose a radial deviating force on the finger. So the way to test it is by putting the finger, the MP joint. Let's see, how can I explain this? Well, here, MP joint in extension, we pull into the intrinsic muscle, and then the patient in this position will not be able to flex the PAP joint because the intrinsic muscle prevents the PAP joint to be flexed. Here, maybe we can see it better. If the ulnar intrinsic, this small finger, ring finger, middle finger, and then if we put the finger into aligned into radial inclination, the patient will not be able to flex the PAP joint. But if we allow the finger to go into radial ulnar inclination, then she will be able to flex the PAP joint. So this patient has a shortening only of the ulnar intrinsics, not of the radial intrinsic. Well, I repeated myself, sorry. Well, let's look at the deformities that we can see on the fingers. Now, until now, we have seen only at the MP joint, but now we have to, I would like to examine with you the deformities that we can see in the interphalangeal joints. In extension, all bones are collinear, are aligned metacarpal, proximal, middle, and distal phalange. In at rest, they're all flexed, usually a little bit more the MP joint, a little bit less the PAP joint, and less the DAP joint. But it's always a cascade proportional flexion of the joints. The claw deformity is defined as an extension of the MP joints in flexion of the interphalangeal joints. This is a claw deformity. And there are two types of claw deformities. A permanent, which is from intrinsic muscle paralysis, from a median and ulnar nerve lesion, in which the patient will always have a claw deformity. And the other one is a voluntary, so you have to be careful with this voluntary, which is a patient that has a flexion contracture of the PAP joint. A patient that has a flexion contracture of the PAP joints, in order to get all the fingers aligned with the same plane of the hand, he will hyperextend or extend the MP joint. And this is just a voluntary claw deformity, but it's not a true claw deformity. A boutonniere deformity, it's a flexion of the PAP joint, an extension of the DAP joint, which is completely abnormal on a normal anatomical basis. SWAN neck deformity is the reverse of a boutonniere deformity, extension of the PAP joint and flexion of the DAP joint. We won't have time to we will not have time to talk about SWAN neck deformities because it's very interesting. subject, but it's not a problem of the extensor apparatus. SWAN neck deformity is a problem with the flexor tendons. It's secondary to a synovitis or not use of flexor tendons. That's so. Well, if you want, later on at the discussion, we'll talk about a little bit about SWAN neck deformities. In mallet finger deformity, it's quite simple. It's just a flexion of the DAP joint, while the other two are in extension. Now let's look at the synovitis of the PAP joint in rheumatoid arthritis, because in trauma, as we said before, they're more straightforward injuries and easier to be treated. If we have a synovitis of the PAP joint here, the synovitis, as we said before, will destroy the soft structures, which are tendons. They will destroy the cartilage also, destroy collateral ligaments, even in the PAP joints, although these are really true collateral ligaments, because the extension forces, we don't have the intrinsics here, so we don't need the collateral ligaments to go from the dorsum to volar, like in the MP joints. This is the volar plate, or the volar plate or volar capsule, but here inserts proximally into the height of the proximal phalanx. And this is why we cannot passively hyperextend the PAP joint, but we can do it with the MP joint, because in the MP joint, the volar plate does not insert proximally. And that's it. This is why we can hyperextend the MP joint and not the PAP. But the synovitis will elongate the central slip, and also the lateral bends, although this will be spared most of the times, because what will happen first is the destruction of the loose connective tissue that we'll see now, that's connecting the central slip and the lateral bends. So all deformities in the fingers, all tendon deformities or subluxation, they're not secondary to tendon synovitis, because there is no synovium around the extensor apparatus. They're always secondary to the underlying joint synovitis. All the alterations, ruptures, elongations, etc., of the extensor tendons at the MP joints or PAP joints are secondary to joint synovitis. So it's the problem. It's more difficult sometimes to understand. You can see a swollen finger like this, that many people will say, well, this is a dactylitis. Yeah, the finger is swollen, it's inflamed. But this is really the beginning of a synovitis of the PAP joint. Synovitis of the PAP joint first enlarges the dorsal capsule here and the volar capsule right here. Here we can see the extensor tendon, the central slip, which is still attached to the base of the proximal phalanx. Here's the subchondral bone of the proximal phalanx, and here there are some erosions of the synovitis into the bone also. And here the flexor tendon. So as we can see here, we can see synovitis below the central slip and over on the dorsum and distal to the central slip. But the central slip is still intact, because we can see here on the left the central slip, lateral bends, one lateral bend, the other lateral bend, proximal phalanx, and this is the pulley of the flexor tendons. This is a normal anatomy. And if we have a synovitis and we do an MRI, transverse section, we'll see that the synovitis will pierce, will go through, herniate between the central slip and one lateral bend. Here completely destroyed the union between the central slip and the lateral bend. And here it's beginning to do the same thing. And here we can see the same in another MRI. And here in a clinical example, we can see this is the dorsum of the finger. This is a zigzag incision on the dorsum of the PAP joint. And we can see the herniation of the synovium on this in between the central slip, which is intact, and the lateral band, which is really still intact. So the lateral bands, in these cases, since there is no union between the lateral bands and the central slip, they dislocate anteriorly to the axis of rotation of the proximal phalanx and cause more flexion of the PAP joint. And then the condyles of the proximal phalanx, this is the proximal phalanx, they protrude in between both lateral bands. And this is why this disease is called a boutoniere. Deformità all'occhiello in Italiano, deformità tenojal in Spanish, deformación a boutoniere in French, and buttonhole deformity in English, because the head of the proximal phalanx protrudes in between both lateral bands, and this is the buttonhole, the boutoniere. So what happens is an attenuation of the extensor apparatus, as we said before. But the extensor apparatus is not just the central slip and the lateral slip. It's this tissue that interconnects the central slip and the lateral band. Here we can see this tissue, this structure, which is quite strong, holding the central slip and the lateral band together. Here we have the transverse retinacular ligament holding the lateral band more or less around here, just dorsal to the axis of rotation of the PAP joint, and here the triangular ligament in a normal circumstance that prevents the lateral band to displace excessively volarly. I'm showing this because if you want to reconstruct the boutoniere, which is one of the most difficult structures to reconstruct, you have to divide always the transverse retinacular ligament in order to replace the lateral band dorsal to the axis of rotation. And also you have to do application of the triangular ligament to prevent new displacement of the lateral band. It's very important to understand the distal extensor tendon, which is here, the one that flexes the DAP joint, needs further displacement. I didn't say it right. The extensor tendon needs further displacement here at the dorsum of the PAP joint in order to flex simultaneous flexion of the DAP joint. And how is this accomplished? Because of the lateral bands, when we flex the PAP joint, they displace anteriorly to the axis of rotation. In this structure that we saw before, this connective tissue holding the central slip and the lateral bands together has to elongate, has to change the shape. Doesn't elongate because this is collagen, and collagen it's practically inextensible, but it changes the shape like, well, we'll see it in the next drawing. Here's the finger in full extension with the picture taken from one side, lateral band, dorsal to the axis of rotation, and central slip inserting here at the base of the proximal phalanx. And here, with the finger in flexion, is a picture taken from the end of the finger towards the wrist. We can see that when we flex the PAP joint, the central slip stays where it should stay, in the trochlea provided by the proximal phalanx, and that's why the proximal phalanx has this shape to allow maintain the central slip in its place. And also the condyles of the proximal phalanx, they are obliquely oriented this way to allow the lateral band to displace dorsal and volar to the axis of rotation, and that's why it has this inclination. This is the collateral ligament, which is really strong in the PAP joints, The bone is much narrower than the knuckle. If we look at the knuckle, the bone, if you look at the X-ray, is much narrower because we don't have intrinsic muscles here to stabilize the PAP joint. The PAP joint is stabilized, one by bone morphology and the other one by the strength of the collateral ligaments. That's why we never see instabilities after injuries of the collateral ligaments, even complete ruptures. We'll never see an instability of the PAP joint. We may have stiffness, but no instabilities. Let's see, did they want to show something else? Probably not here. Let's go to the next one. Here we see the finger in extension. This is the PAP joint and the AP joint, central slip, lateral bends. And here, as we flex the PAP joint, we can see that the central slip stays here in the trochlea provided by the condyles of the proximal phalanx. And here we have a thickening, which is called the volar dorsal plate of Slattery, because the one that described it, and the extensor tendon really ends up here approximately. And this is like a fibrous tissue, it's like a patella. Patella, it's to protect the bone, because the bone is designed for traction, but not for compression. And this is the reason why there is like a thickening here, like a patella. But the extensor tendon doesn't go really to the very end of the joint. Well, maybe the dorsal fibers, but not the anterior fibers. And this is what happens to this collagen tissue that's holding the central slip and the lateral bands together. In flexion, this collagen tissue is arranged in such a way that should allow the lateral bands to move distally to allow flexion of the DAP joint, and laterally, precisely for this, to allow flexion of the DAP joint. And these are, as we saw before, the stabilizers of the lateral bands. So it's very important to know that the lateral bands, they're only extensors of the joints when the joint is in extension. But when the joint flexes, the lateral bands flex the PAP joint. Another thing that we would like to mention is that if you cut just the central slip, preserving the triangular ligament, so you always have the lateral bands on the dorsum of the PAP joint, you will never have a boutonniere deformity or a loss of extension. In order to have a boutonniere deformity, it has to be always an anterior displacement of the lateral bands. This is a normal finger. And here on the left, it's my finger in full extension. PAP is an extension, DAP is an extension. If I flex the PAP 30 degrees, let's say, the DAP flexes about 15 degrees. If I flex the PAP 70 degrees, the DAP flexes 45 degrees. So there is always a balanced flexion of both joints. When one flexes the PAP joint, the DAP joint flexes. And for example, if you put two fingers together, touch the back of the fingers, and then you flex the PAP joint, you will see that the nails spread apart. And even if you want to get them touch actively, you will not be able to. You can do it passively. Why? Because the extensor tendon is not able, the lateral bands are not able to extend the DAP joint. So now in summary, here we have all the extensor apparatus, in green, the extensor apparatus, and in blue, the stabilizing structures. And finally, one structure that we didn't mention in the entire almost 60 minutes that they have been talking is the oblique retinacular ligament. And this is something I'm leaving to you to think about, because it's quite interesting. What is the oblique retinacular ligament function? I don't know. It looks like an intrinsic when you think about, because it's volar to the axis of rotation of the PAP joint and dorsal to the DAP joint. So it's like an intrinsic but passive intrinsic because it has no muscle belly, but intrinsic to the interphalangeal joints, not to the MP joints or to the finger as a whole. I don't know if there is much of a role of the oblique retinacular ligament unless you try to reconstruct it like to correct the SWAN neck deformity, like the technique that James Thompson, a personal doctor that trained with Littler at Roosevelt Hospital, designed, which is to reconstruct the oblique retinacular ligament to correct the SWAN neck deformity. SWAN neck deformity will be hyperextension of the PAP joint and flexion of the DAP joint. By reconstructing the oblique retinacular ligament with a tendon graft going from the distal phalanx to the proximal phalanx, he will correct the flexion of the DAP joint and the extension of the PAP joint. In this, to show you that this is not a boutonniere deformity, and this is not a boutonniere deformity. This is a boutonniere deformity. For a boutonniere deformity to be defined as such, we need to lose this balance or this proportion of flexion of both interphalangeal joints. A boutonniere deformity, it's defined when the PAP joint is flexed and the DAP joint is not proportionally flexed. It's either in extension, doesn't need to be in hyperextension here. At first will be just in extension. This is just beginning of a boutonniere deformity in a rheumatoid patient. So we always have to do a careful examination, otherwise we can be misfooled, like this fox here. So, as I said before, a boutonniere deformity is an alteration of the extensor apparatus. So the finger should look this way. Thank you very much for your attention.